I'm going to talk about proximal humeral fractures today, and quite a common fracture. We all know the anatomy of the proximal humerus. Shoulder is a ball and socket joint, quite unlike the hip. So the rotators are very important. All the muscles, subscap, supraspinatus, infraspinatus, teres minor are important muscles around it. So we have to respect the soft tissue in addition to the bones. So it's quite a common type of fracture, accounts 4 to 5% of all the fractures, proximal humeral fractures. And in young people, it is a high energy fractures. However, in elderly, it can be a low energy fracture as well. Fracture mechanism is commonly fall on outstretched hand. Vascular anatomy is very important to know in proximal humeral fractures, especially the complex ones, because in multifragmentary fractures, you have got problem with avascular necrosis of the humeral head. So there is an anterior humeral circumflex artery. There is an arcuate artery which goes through the bicipital groove. There is a posterior circumflex humeral artery, and those form an anastomosis around the surgical neck. So if there is an inferior spike attached to the head fragment, probably the head is viable and you might get away with the fixation. So there are two classifications which are commonly used. The commonest one is the Neer classification, which divides shoulder fractures into 2-part, 3-part and 4-part fractures, and they are sub-classified into articular segment, anatomical neck, shaft segment, greater tuberosity fractures, lesser tuberosity fractures, fracture dislocations, and posterior type of fractures. Similarly, there is a AO classification, which basically important to know A, B, and C type of fractures. A type of fractures are extra-articular or unifocal fractures, which are amenable to open or close reduction. B type of fractures are a little bit more complex, more like 3-part Neer's classification, where the fractures can be bifocal or trifocal. And C type fractures are complex type of fractures. Additionally, I find this concept really interesting, but I still don't find it adequate to describe proximal humeral fractures. Many of us have played with these Lego bricks in the childhood, where the red segment is the head segment, the blue segment is the greater tuberosity, yellow is the lesser tuberosity, and green is the shaft. And there have been 12 subtypes of proximal humeral fractures depending upon which Lego brick is got dissociated from each other. So still I don't find it adequate. Just read it up, and it's been proposed by Hertel. What I find really challenging is the shattered red fragment, which is the shattered head, which makes proximal humeral fractures really complex. There are various complex scenarios, and some of them, those don't fit into any classifications. That requires the need of describing proximal humeral fractures better, and we need a better classification. So important to know that what are the predictors of avascular necrosis. Number one, fracture dislocation and anatomical neck fractures. These two we have known since student days, that in a fracture dislocation or anatomical neck fracture, the humeral head might lose the blood supply and there might be avascular necrosis. But in addition to that, Hertel came up with a paper in 2004, and two additional predictors were added to that, that 8 millimeter calcar is needed in order to predict viability of the humeral head. Number two, if there is disruption of the medial hinge of the humeral head, then probably that it may not be viable. We still tend to fix it. The picture on the right is typical, where the medial hinge is displaced. So how do you assess a patient with proximal humeral fracture? Check the swelling, check the axillary nerve, check the musculocutaneous nerve. Any brachial plexus damage has to be documented prior, and different types of imaging. And positioning for the surgery is very important, so our X-rays taken intraoperative are clear. Imaging wise, classic X-rays, AP X-ray, axillary X-ray if possible, scapular view, and a traction view is quite useful. A 3D CT and MRI scan is very useful in assessing complexity of the fracture, how many fragments we have, and MRI scan to see if the rotator cuff and subscapular is intact. Operative treatment, we know that we can treat it in different ways, many ways to skin a cat. This is quite a good way to fix a two-part fracture, which is displaced. It can reduce the fracture, but typically these wires are not very well tolerated and patients don't like such constructs. Intramedullary nail is something which I am not a fan of. A couple of ways to put intramedullary nail, good for two-part fractures, knee types. Surgical approaches for intramedullary nail in a beach chair position, extend the shoulder and go straight down the shaft. Miscellaneous fixations already covered by Dr. Marfatia. Plates and screws, different types of plates and screws have been devised. Locking plates are the ones which we use most commonly now. Patient positioning is such that we are able to get proper X-rays. Surgical approaches, now that's very important. I was going to ask a question that in a lateral approach, do we have to detach the deltoid of the acromion, but we'll come to that later. Most people are comfortable with deltopectoral approach. I got a couple of tips to add over there. Anterolateral approach is good, but it might damage the axillary nerve, so you can only go so far down with an anterolateral approach. Transdeltoid or lateral approach is again a limited approach. It is not an extensile approach because we cannot go below the danger zone as described by Dr. Umralkar. So in a deltopectoral approach, I always find that is an excellent approach. It can be extended into anterolateral approach. However, placing the plate lateral and getting the fracture reduced can be sometimes very tricky. So what I do in these fractures is, after doing the deltopectoral approach, I tend to abduct the arm, put a spike under the subacromial space, and take a control ethibond stitch through the teres minor and infraspinatus. So that gives me something like a rein, godeka lagam. There is one in your left hand, one is in your right hand. The one on the right goes through the subscap. So we have got this two reins of the parachute to control the entire humeral head, where it typically it works like that you have got control on humeral head. You can put the head in valgus, you can control the extension, you can control the flexion, and that's how it looks once you fix it. And there's, I think, one slide missing over here. In a fracture dislocation of the shoulder, the humeral head is sometimes difficult to retrieve without stripping of the soft tissues. Do not be afraid of doing a osteotomy of the coracoid process. So once I tie the reins over there through the plate, I pass the plate down to the shaft. I use the cortical screw, which is in the oblong hole, to pull the shaft and to get a perfect anatomical reduction. So for a 3-part, 4-part fracture, that is quite useful to do that. So I got a couple of slides missing from here. I'm sorry about that. That's what we do in 3-part, 4-part fractures. Additionally, in a fracture where the head is displaced, it is important to make a cut in the rotator interval, separate your two reins, your subscap and your teres minor, push the head into valgus by your thumb, and to get the reduction to fit the plate on. My take-home message here is decide when not to fix. Some of these fractures are quite nasty. Bone stock is very poor, rotator cuff is non-existent, and they are impossible to fix. Once you go in there, bone pieces come in the hand, so it's important to be able to figure out which fractures not to fix. That's why we need a better classification. These I call unreconstructable fractures, fair enough to fix with sutures or K-wires, with shattered head, severe osteoporosis. The rain technique which I have been following makes my proximal humerus fracture easy and predictable. So please try to do that. Push the head fragment with thumb for indirect reduction and coracoid osteotomy if needed. Thank you.